Foe from the GME office, and then he will introduce Catherine to introduce our speaker. So,
great.
Thanks.
Eric.
Get out of the way.
Okay, so this is a mandatory training from the GME office to follow up an NRMP allegation of violation of the match, not from our program, but because of this at the recommendation of the NRMP, the National Residency Match Program. All programs across the institution are required to report this to their faculty and to provide them training. So this serves as your training over the next 2 minutes. So the alleged violation occurred when one program, which you do not know which it was, asked one of the applicants which program that person was interested in and or ranking. And so to mitigate any future errors by interviews, all programs are required to educate their faculty on National Residency Match Program criteria. So these are the educational materials which I've sent out to all of our interviewers, and the GME office is going to respond to NRMP with this following proposed education, including this meeting as well as GMEC meetings at the to educate all of our faculty. So essentially what we're talking about here is that we must, as a program, accept the responsibility for all of our interviewers to promote transparency and minimize bias during our interviewers, and that we should know that there are some do's and don'ts in the recruitment process. And these are really the take-home messages. As interviewers, you're not allowed to ask recruitment questions or activities, including but not limited to questions about race, national origin, sexual orientation, or focusing on communication with the applicants about the applicant's interest in or other programs. We want to recruit applicants that are interested in and align with our program's mission, aims, and eligibility. So with regards to post interview communication, that can be initiated by the applicants, but in general, interviewers should not initiate post-interview communication back to applicants. In addition, specifically, we may not request an applicant disclose ranking preferences, ranking intentions, or the specialty or locations of other programs to which the applicant has applied or may apply. We are not to ask about or require second visits. We're asked to limit post-interview communication. And our job, as we submitted our rank list today, is to rank our applicants based on tools and resources that limit bias or discrimination of applicants or specific applicant groups. So that's the overview. Please contact me if you have any questions about any of these. But the common sense is if there's personal questions outside of the application, the best strategy is not to ask the applicant. So I'll now introduce Catherine Clark to introduce our speakers. And again, here's the Grand Rounds CME ID. Thank you.
Thank you. And just quick announcements. You can see the upcoming Grand Rounds talk. Next week, we have Dr. Kirkpatrick, some faculty meetings, fellows, Andrew, and then Katie Burlacker before the holidays. So please join us, some exciting speakers. Yeah. Okay. So now it's my pleasure to introduce two of our fellows. First, you come up and join me. They will be co-presenting, so I'll introduce them both starting off. Dr. Sean Parikh is a second-year cardiology fellow. He completed his undergraduate and master's degrees in physiology and neurobiology at the University of Connecticut. He then went on to the Vanderbilt School of Medicine, where he earned his MD, as well as his PhD in pharmacology at the Vanderbilt Center for Arrhythmia Research and Therapeutics. His work there focused on investigating excitation-contraction coupling in the context of inherited cardiomyopathies. He then joined the physician scientist training program here at Yale, where he completed his internal medicine training and is finishing his clinical training in cardiology, with plans in the upcoming year to return to the lab to study metabolism and heart failure. And then Dr. Andy Shahu was born in Tirana, Albania, and grew up in Washington, D.C. He obtained his undergraduate degree from Johns Hopkins University, where he majored in molecular and cellular biology and French. He obtained his medical degree here at the Yale School of Medicine, and then completed his internal medicine residency back at Johns Hopkins Hospital and served an additional year as the Assistant Chief of Service of the Osler Medical Residency. His clinical interests include critical care cardiology, cardiovascular disease prevention, and echocardiography. His research interests lie at the intersection of cardiovascular outcomes, health equity, community engagement, and health policy. Now I'll let these gentlemen take it away.
Thank you very much, Dr. Clark, for that wonderful introduction. I wanted to start by thanking our faculty mentors, Dr. Shaw and Dr. Pfau, who not only always welcome us into the cath lab at the West MBA, but have been integral in the formation of this presentation and providing constructive criticisms to help us improve it. So we really appreciate their help. They unfortunately could not join us to start with tonight, but you know, it was very helpful to speak with them. No disclosures for either of us. I'll review the learning objectives for this discussion today. First, we're going to review current guidelines on antiplatelet use for secondary prevention in stable ischemic heart disease. We're going to dissect data on the use of aspirin for secondary prevention in stable coronary artery disease. And we will then evaluate data supporting the superiority of the P2Y12 inhibitors over aspirin for secondary prevention. And lastly, we'll discuss the challenges and pitfalls of P2Y12 inhibitor implementation. So antiplatelet agents are essential for the secondary prevention of cardiovascular disease, and aspirin has been touted to be, critical for this and has been the cornerstone of treatment for decades. And despite evidence for potential superiority of alternative agents since 1996 or so with the Capri trial, aspirin has remained the agent of choice. There's been a reduction in recurrent MIs, which is likely multifactorial, not only for antiplatelet, but I couldn't find data that would compare this much further, but I imagine it's a larger effect. But regardless, the rates of recurrent myocardial infarctions continue at about 16% at 6 years, suggesting that there's quite a bit of room for improvement. And so with that, we're hoping you can all participate and help us understand what the spread in practice is. We have Mr. V here. He's a 65-year-old gentleman with past medical history of coronary disease with a stent in 1999, multiple risk factors with hypertension, poorly controlled diabetes, obesity, an inguinal hernia. And he's coming in to establish care with cardiology. And from a cardiac perspective, he's been doing quite well. He's been compliant with all of his medications, including aspirin, clopidogrel, lisinopril, and he asks if any medication changes are necessary. So what would you do at this stage? This happens to us very often in fellows clinic. So would you continue DAPT, and due to the high risk for recurrent cardiovascular events in the setting of his, poorly controlled diabetes and hypertension, would you continue discontinue clopidogrel and continue aspirin monotherapy? Would you perform genotyping prior to transitioning to clopidogrel monotherapy? Or would you discontinue aspirin and continue clopidogrel monotherapy? You could all scan the QR code, or you could just visit pollev.com/happyguide469. You can answer, and I will pull up the poll. So command, Control Command. Oh, sorry. Drag it over. All right. Oh, it's poll EV. Oh, should I go back to the QR? Yeah. Sure. Sorry about that. Changed it too quickly. Oh, okay. Is it not working? No. So it's active. Okay. All right. Well, we won't spend too much time on that, but maybe with the raise of hands, would people change to aspirin? We can revisit this at the end. Okay, so I'll start with the rise of aspirin. You know, a lot of the work on aspirin originated from the early 1970s, based off a variety of trials, which I'm not going to belabor too much, but I wanted to point out a couple of factors. The first one is that, you know, there was about 6 of these trials, between these years that, enrolled patients, at some variable time after an MI, ranging from about 3 months to, about three months to multiple years, up to 25 months. And they were either in the aspirin group or no aspirin group. And it was predominantly male, and they had a very high aspirin dosing regimen, anywhere from 300 milligrams to 1,500 milligrams. There was a mixed use of aspirin and dipyridamole, which we don't use much anymore. And the follow-up was maximally only about 41 months, with an average of about 25 months. And interestingly, there was minimal to no statistically significant reduction in primary outcomes in any of these trials individually. But there was definitely a signal, just tended to cross the confidence intervals, but there was a signal for reduction in vascular events. And as such, there was a formation of the Anti-Thrombotic Coalition, which completed 3 large meta-analyses on various randomized trials to evaluate the efficacy of antiplatelet therapy in secondary prevention. And the first of which was done in 1998. And I just wanted to point out here, it's about 29,000 patients. There was this variability in antiplatelet use that I discussed. And overall, there was pretty strong data. There was pretty strong suggestion that there was a reduction in vascular events, with a reduction in vascular death by up to 15%. So both strokes and myocardial infarctions. The second large meta-analysis was completed in 1994, and this was with over 100,000 patients. And there was definitely a reduction in the absolute risk reduction of vascular events overall, but also of non-fatal MIs, and a signal for reduction in any deaths. But it's interesting from this, you could see that a lot of this benefit was seen in the first and second year, and it kind of decreased as the years went by. The third meta-analysis was completed in 2002, and this was done with a lower aspirin dose, anywhere between 81 to 325 milligram. And a lot of this data was more in the primary prevention, but there was still a subset of secondary prevention. And this again showed this reduction in recurrent myocardial infarctions. But again, it showed that there's a statistically significant reduction in overall death with aspirin, which seems to be a fairly strong signal. But there was a lot of trials, a lot of people, and there's a clear signal that there's a reduction in vascular events, specifically in recurrent myocardial infarctions, suggesting that in the first 1 to 2 years is definitely protective. I think that much can be gleaned from all of this information, but there's definitely also risk. And I think that a lot of what people think about outside of cardiology with aspirin is the increased risk of bleeding. And although this is from the adaptable trial, similar values were seen in some of the other evaluations of this data, and that what they found is there's significant risk of GI bleed, both intracranial and both GI and intracranial bleeds. And this risk is up to 0.6%. And I think that this is important because it really questions, the lifelong use of aspirin for secondary prevention, especially if the original data showed that the protection against vascular events may just be in the early setting. Now, what if we were to stop using aspirin and in favor of other antiplatelet agents because, there's clearly a lot of work to be done in terms of preventing recurrent MIs. And in fact, there were these studies that, used other antiplatelet agents such as ticagrelor or prasugrel with very early discontinuation of aspirin. Although these studies have limited follow-up to 2 years, which is kind of where that benefit was found with aspirin, it doesn't seem that discontinuation of aspirin seems to cause harm when alternative agents are used. And I think that's important. But there is a decreased risk of bleeding, which is something that we continue to see in trials as we discuss the further trials later in this discussion. So, I think that the data for aspirin has been longstanding, but there is a lot of discussion on the validity of that data for, lifelong use and whether there are agents that are superior. And I think that a lot of the foundation of this work was done off these early trials. And, there's a clear risk of bleeding that is not insignificant. And, I think a lot of what we see on consult services, patients with GI bleeds, and we get asked about, stopping various antiplatelet agents. I think this is a big problem. And, there's limited follow-up that was evaluated in this aspirin studies, up to 24 months on average. So can this really be extrapolated to a lifelong benefit? And I'm not going to go into data, but there is data on aspirin resistance. And while you do have, genetic differences in populations, which can, also result in Plavix resistance, I think aspirin resistance is less discussed, and there is definitely increased recognition of this. And so to be on this lifelong may actually increase the risk of, recurrent events, if this study were to be continued for 20 years, let's say. And then, there are alternative agents which may be superior for reducing MI and reducing bleeding. And I think that, it's interesting to go over what the guidelines say before diving into the other antiplatelet agent data. So I'll let Dr. Shaibu now take over.
Okay. So what do the guidelines say about the use of antiplatelet therapy for secondary prevention of coronary artery disease? These images are from the 2023 AHA-ACC guidelines for prevention of chronic coronary disease, which is defined as anyone that has evidence of coronary artery disease, whether it's someone that's had a prior myocardial infarction, someone that's had a prior PCI or a prior ACS event. And you'll see that the guidelines aren't too specific in their recommendations. I'm not going to go over all of them, but I'll just highlight a few. So first, we have a class 1 recommendation for aspirin for patients with chronic coronary disease, which forms the basis of what we generally recommend. People with CAD should be on aspirin is what we typically say. And then for patients who are post-PCI, dual antiplatelet therapy for at least 6 months is recommended, followed by single antiplatelet therapy afterwards. But you'll notice that it doesn't specify what we should narrow to after that dual antiplatelet therapy period. The remaining recommendations are weaker and generally focus on things that would impact the duration of dual antiplatelet therapy and other special circumstances such as post-CABG patients. But I was also going to point out that there is no benefit for patients that have a more distant history of an ACS event to adding clopidogrel on top of aspirin if they're far enough out. This is sort of a more visual representation of those recommendations. So for patients who have a history of coronary artery disease and are more than 12 months out from an ACS event, aspirin would be recommended. For patients who have had an ACS event, dual antiplatelet therapy would be recommended for the first 12 months, followed by either de-escalation or continuation of DAPT, depending on the thrombotic risk of the patient. And then post-PCI patients would be on dual antiplatelet therapy for 6 months and then de-escalated, but that duration would change depending on the amount of bleeding or ischemic risk. Meanwhile, the European Society guidelines generally are pretty similar to the American guidelines. These are from 2019, and they recommend aspirin for any patient that's had a previous myocardial infarction, who's been revascularized, and then also for patients who have definitive evidence of coronary artery disease on imaging. And for Plavix, the recommendation is to use it if patients are intolerant to aspirin, and also to add Plavix to aspirin for patients that are post-PCI. The one interesting addition here is that clopidogrel is recommended in preference to aspirin for patients in certain populations. So that would be patients with a history of PAD or ischemic stroke, although that's a weaker recommendation and a 2B recommendation, which is based off of the CAPRI trial, which I'm going to talk about shortly. So there raises the question then, how do we choose an antiplatelet agent for someone that's previously had an ACS event or a PCI? Do we have data to look at that tells us whether we should be de-escalating everyone to aspirin or whether we should be using an alternative agent? So in reviewing the literature, I'm going to highlight a few studies. First is the CAPRI trial, which was published in 1996. The host exam trial, which was published in 2021, and then the Panther meta-analysis, which came out in JACC a couple months ago. So first, CAPRI. So this was one of the most prominent trials that suggested that P2Y12 inhibitor monotherapy might actually be superior to aspirin use in patients with ASCVD. It was a large randomized blinded international trial that enrolled about 19,000 patients with known ASCVD. And it defined that as people who had a history of ischemic stroke, myocardial infarction, or peripheral artery disease. And it randomized them to either clopidogrel 75 milligrams daily or aspirin 325 milligrams daily. Followed them for a mean of 1.9 years. The population was 72% male and 95% white, and the primary outcome was a composite of ischemic stroke, MI, or vascular death. The forest plot on the left, top left, shows the cumulative risk of the primary outcome, so the composite of ischemic stroke, myocardial infarction, and vascular death. And there was a relative risk reduction of 8.7% for the clopidogrel group over aspirin. The table on the right provides more information about that. It shows more of the numbers for the primary outcome and then also for the secondary outcome. The secondary outcomes, unlike the primary outcome, were not statistically significant. The other thing is the figure on the bottom, which looks at the relative risk reduction and separates the patients out depending on what subgroup they came from. So whether they had a prior MI or a prior stroke or prior PAD. And interestingly, the prior MI subgroup didn't seem to benefit as much from clopidogrel as did the other groups. And I think that is sort of what formed the basis for that weak recommendation in the European guidelines, suggesting that clopidogrel could be considered instead of aspirin for patients who had a history of ischemic stroke or PAD. So the conclusions that were drawn from this trial is that in patients with known ASCVD, clopidogrel may have a greater benefit than aspirin in reducing additional major cardiovascular events. This was the first large study of antiplatelet therapy to include patients with stroke, cardiac, and peripheral arterial disease under one common protocol. So that was one major benefit, but there were a number of issues. One was that the trial was not powered to detect a treatment effect in the clinical subgroups. The trial diversity was pretty limited. The dose of aspirin that was used was much higher than what we normally use in everyday practice. And the treatment effect was relatively small. And there wasn't really a clear explanation as to why the group that had a previous MI seemed to benefit less from clopidogrel than the other ones. So ultimately, this did not lead to a shift in clinical practice because one, the treatment effect was kind of modest, and two, at the time, 1996, clopidogrel was a very new drug and was a lot more expensive than aspirin. So this brings me to the host exam trial, which was done in 2021. Now in the modern PCI area, patients are receiving drug-eluting stents, are on statins. So this trial specifically looked at patients who were on dual antiplatelet therapy for 6 to 18 months after receiving a PCI. It was done in South Korea and enrolled 5,530 patients and was an open label trial. And it randomized people to either clopidogrel 75 milligrams daily or aspirin 100 milligrams daily after they had completed their requisite period of dual antiplatelet therapy. The follow-up period was 24 months, and in this case, their patients were 75% male and on average 64 years old. The composite outcome here was a composite of all-cause death, non-fatal myocardial infarction, stroke, readmission due to ACS, and major bleeding. So what were the main findings here? Well, in the top figure, you see a graph of the cumulative incidence of the primary endpoint. So that includes all thrombotic and bleeding outcomes. And it shows that there was a reduced risk of this outcome, this composite outcome with the clopidogrel group. So clopidogrel was better. And the hazard ratio there, if you can't read it, is 0.73. In the second figure in the middle, this focuses on a secondary composite outcome, which is specifically thrombotic events, not including bleeding events. And again, clopidogrel was better. And then in the third figure, it just focuses on bleeding events. And again, the clopidogrel group had a lower risk of having bleeding. So the conclusions that they drew in this case were that clopidogrel was associated with a lower risk of adverse cardiovascular events during the trial period, and that the benefit was observed for both thrombotic and for bleeding outcomes. And then I didn't show you this, but the results were consistent across major patient subgroups. One major strength of this is that this was really the first large-scale RCT that compared clopidogrel and aspirin monotherapy in patients who had received PCI and dual antiplatelet therapy and were on modern therapies. And then unlike Capri, the aspirin dose that was used was a lot more in line with what we use in our day-to-day practice. But still, this had its own issues. One was that the event rate of the primary endpoint was lower than anticipated. Two, the reduction in adverse events did not actually translate to reduced risk of death. Three, phenotypic and genetic testing for clopidogrel resistance wasn't done. The study was only conducted in East Asian patients. And then finally, and confusingly, there was actually a trend towards increased mortality in the clopidogrel group, even though the outcomes seemed to be better. Although that seemed to be driven largely by non-cardiac and cancer-related deaths. So in order to address this discrepancy of the outcomes being better, but the mortality being potentially worse, the investigators actually decided to extend the host exam trial and continued follow-up to a median of about 5.8 years. So same trial, same outcomes, same initial patient population, but just continued for almost 6 years. And what were the outcomes there? They were actually pretty similar. So for the primary endpoint, which is again a composite outcome involving both thrombotic and bleeding events in the top left, clopidogrel again was less likely to lead to that event. In the bottom left, we have the secondary thrombotic outcome, which is only looks at thrombotic events. And again, clopidogrel was better in that case. And then in the top right, looking at major bleeding, clopidogrel again was less likely to be associated with major bleeding events. And then finally in the bottom right, all-cause death, there was no statistically significant difference between the two groups, which kind of suggested that the previous concerns about mortality difference in the initial trial might have been overblown. So the conclusions that were drawn here were that the outcomes were largely the same when extended over 5 years. Although the treatment effect was pretty modest, the absolute risk reduction was 4.1% with a number needed to treat of 24. And then this trial was not powered to detect a mortality difference. The other thing I was going to mention, which is not really shown in any figures, is that in the aspirin group was actually more likely to have discontinuation events due to issues like GI discomfort and bleeding events. So this then brings me to the Panther meta-analysis. So this was a large meta-analysis that was published early this year that took data from 7 RCTs that had a total of about 24,000 patients. And 7,500 of those patients received clopidogrel, 4,600 received ticagrelor, and 12,000 received aspirin. In this combined group of participants, the participants were 78% male. They had a mean age of 64. They were 24% Asian, most of which was represented from the host exam trial, and then 57% European. And then this group, they included trials that had patients who had confirmed coronary artery disease, patients who are post-PCI, and also patients who are post-CABG. So clinically speaking, a little bit more of a diverse patient population. In terms of the primary outcome, that was a composite of cardiovascular death, myocardial infarction, and stroke. And then the secondary outcome was major bleeding. Patients who were concurrently on anticoagulation were, or trials that included those kinds of patients were not included. In the figure on the left, you see that the primary endpoint was less likely to occur in the group that received P2Y12 inhibitor monotherapy as compared to aspirin, and the table below that breaks it down into each individual trial. Might be a little bit hard to see, but host exam is the one that contributes the most, it seems, to that effect. On the right, they looked at major bleeding, and the conclusion that was drawn there is that the risk of major bleeding was not statistically significant between the two groups. The confidence interval crosses 1, but there seems to be a trend towards less bleeding in people who received P2Y12 inhibitor monotherapy. Additionally, in figure 4, which is on the left, they looked at myocardial infarction alone as an outcome, and that was significantly lower in the participants who received the P2Y12 inhibitor. And then finally, the central illustration on the right sort of puts everything together. and essentially highlights that for a lot of the outcomes, including the primary outcome and myocardial infarction and hemorrhagic stroke and stent thrombosis and any GI bleeding, clopidogrel was favored. The conclusions here was that there was a significant reduction in adverse ischemic events without actually increasing bleeding risk with P2Y12 inhibitor monotherapy. This was a helpful study in the sense that it was the most comprehensive synthesis of individual patient data from RCTs that compare P2Y12 inhibitors and aspirin in secondary prevention of CAD. And it included a relatively broad population of patients in the sense that there were patients that received interventions and patients that did not. But again, there were some limitations. As you can imagine, there were different study designs for the trials. Some of them, like host exam, were open label, for example. The trial spanned 3 decades, during which clinical practice has obviously changed. And then there was no actual difference in all-cause or cardiovascular mortality in that two-year period. And then ultimately, the number needed to treat to prevent one primary endpoint over 2 years was still 121. So the treatment effect was still thought to be relatively modest. In totality, I think you could still say that based off of the data that we've seen, it seems like P2Y12 inhibitors are superior to aspirin in secondary prevention of CAD. And that's partially because there's a lower risk of adverse thrombotic events, but also because there seems to be a lower risk of bleeding as well. But there's some additional considerations that we're going to talk about.
So I'd start with, it appears to be superior, but to what end and in who really? And I'm just going to go through some considerations, based off, I'm going to go through a lot of the similar trials that have already been gone through, but looking at particular things in them. The first thing is Capri. So this was supposedly a groundbreaking trial in 1996. And, we see this graph and we see this fairly poor signal for clopidogrel, for antiplatelet therapy and, for P2Y12 inhibitors in MI. And, it was even shown that there was a test of heterogeneity, which suggested that these effects were truly, different between the subgroups. And what they did was they used an additional analysis, which was not pre-specified in the protocol, where they changed the the categorization of patients that they initially had to then include more patients from other arms, including the stroke and PAD, that had like much more remote MIs. And then based off of that, this post-hoc analysis, they said that there was a truly statistically significant difference with that showed superiority in clopidogrel. So, I think that the validity of these claims, I think could be less based off these like post hoc analyses that were not pre-specified in the original kind of trial design. So, and again, the fact that these data have existed since '96 and they still have not been incorporated into guidelines today also makes me think like, maybe there's something else that, I'm not seeing. The second thing is there was a trial there was a meta-analysis called Prospera, which was done in 2020. And what this shows, what I'm showing here is that, based off all these trials, which does not include host exam because this was done after, there's not much of a difference. In fact, they said ultimately there was a signal that favored use of P2Y12 inhibitors, but that was done after they added the trial, the randomized controlled trial called Global Leaders, which then they found that there was a small, superiority of P2Y12 inhibitors over aspirin. And the Global Leader trial was a trial where they used ticagrelor monotherapy over a period of time. So that was a kind of an interesting finding. But regardless of the addition of the Global Leaders data, there was still a marginal reduction in the recurrent MI rate with the number needed to treat of 266, which, again, is compared to the Panther trial, which did have the host exam, is down to 121 for the primary endpoint. They did not show an overall reduction in bleeding risk, but there was a lower risk of GI bleed. So I think regardless, all the trials show aspirin increases GI bleeds, potentially intracranial bleeding, and P2Y12 inhibitors seem to have a lower risk of bleed. So I think that that's hard to argue with. And then there was a comparable risk of all-cause death, vascular death, and stroke. So, I think it's interesting going back to the early aspirin trials, there seems to be a signal that it was protective for, non-vascular related deaths. So is there another, use of aspirin that we're missing out on here? The next component is just dissecting the Panther trial in more detail, and I wanted to show that, kind of just reiterate that there are multiple patient populations here. The first one is that, seen in the yellow, is that there are these fairly medically treated population, which patients may or may not have been stented, or these stents were a different generation than the stents used today. And then we have a CABG group, and we also have a post-PCI group. So that's already 3 variables there. And then on top of that, there's the additional variables of clopidogrel and ticagrelor, which have, while they target similar pathways, they have different, pharmacokinetics. And so, and metabolism. So I think that's, an interesting consideration there as well. So there are multiple patient populations that Panther uses to kind of gain that superiority of P2Y12 inhibitors. And I think this kind of limits the generalizability of saying that P2Y12 inhibitors are better in all comers. And the second part is, further, looking at this data, a lot of the signal is driven by host exam, which is Plavix, which is done in a very specific population in Asia. It's a Korean population. And then TICAB and DICAB, and these are more ticagrelor studies. So, I think that there's a large ticagrelor signal in there as well. And I think that there are differences between ticagrelor and clopidogrel that are not counted in this data, is that ticagrelor is a twice-a-day medication. What are the adherence rates to that? The cost difference, and there's always this shortness of breath issue that's associated with that. So I think that could be a very different signal if kind of further divided. The next kind of interesting point is a lot of the data was, a lot of the signal is seen here in stent rethrombosis, and so a lot of the signal that we're seeing from before is from patients that are post-PCI. So I think that that's a different subgroup. And so when we think about antiplatelet, use, I think there's medically treated patients and those that are post-PCI. So it could be that these are these 2 separate groups, and one may have a better benefit than the other. The next component is when they looked at the kind of the geography here, for Panther, all those randomized control trials, 23% were Asian, but yet the highest signal that we see in this kind of subgroup analysis is from the Asian population. And so there seems to be something very different about that population versus the other populations that may be conferring benefit of P2Y12 inhibitors that make it, superior. And so again, this may limit the generalizability of this data. And so why might this be? Well, there's been this concept of the East Asian paradox. And, you'd think that, because there's an enrichment of P450 C219 loss of function alleles at about 65%, you'd have less metabolism of clopidogrel into the prodrug, and therefore you'd have potentially more recurrent myocardial infarctions, but that's not the case. And I think regardless of that, enzyme, of the genetic differences, this population just has a different set point for bleeding and ischemia. And so I think this has been in the literature, and this is something that's very interesting about this population that suggests that their genetics are very different than the rest. And I think that, to have a very strong signal in just that population, not the others, would require us to complete RCTs in the other population to make sure that it also fits. And so, suggest these alternative mechanisms of protections in that subgroup. And it may not be superior for all populations. In fact, this study is about 44,000 patients in the Bangladeshi of Pakistani ancestry, and you can see the difference is in the metabolism of clopidogrel, and they have an increased frequency of poor metabolizers, and they may not have that same set point that the East Asians have. And there was a correlation of increased recurrent MI in those that are poor metabolizers and intermediate metabolizers, suggesting that this is more of an effect in this subpopulation than in East Asians. So I thought that was interesting, and it would make me think twice about just kind of prescribing this to all comers. And then the last part I wanted to talk about was this increased mortality signal in clopidogrel. Even though the 5-year or the extended host exam study kind of shows somewhat of a normalization, the raw data, there's 1165 versus 1285. There's still a trend towards increased mortality in the P2Y12 treated group. And it's interesting that in the aspirin treated group, there was actually survival benefit. So, we're not seeing a mortality benefit, or really much of a change, but we have a loss of a survival benefit that may have been incurred by aspirin versus the P2Y12 inhibitors. And when we look at data that evaluates the benefit of aspirin in cancers, it seems like that majority. Wait, sorry, what is this one? Oh, sorry. This slide is just showing that in terms of the death that was seen in Panther, the majority of the death is non-cardiovascular death, suggesting that could some of that be cancer related? When we look at the benefits of aspirin, the majority benefit that we see in this meta-analysis here is in the reduction of colorectal cancer. So is there a chemoprotective effect of aspirin that's lost with not having it and switching to P2Y12 inhibitor? So in terms of goodbye aspirin, I'm not so sure yet that it's such a goodbye. I think that there's a lot of considerations regarding the strength of the P2Y12 inhibitor data. I think that maybe these are somewhat equivalent, but maybe they're superior in certain populations. And I think that the generalizability is kind of limited based off the ethnicity and the patient population, whether it be medically managed patients or post-PCI or CABG, but also if you're choosing Plavix versus ticagrelor. And then there's also this loss of survival benefit of aspirin, and how real is that? And I think that longer studies are needed to really understand why we kind of have a loss of that signal. So, which Dr. Sai will conclude.
Okay. So to summarize, we've presented to you all some data that could support the use of P2Y12 inhibitor monotherapy for secondary prevention of CAD over aspirin, although we acknowledge that the treatment effect may be modest. We know at the very least that the risk of bleeding seems to be lower pretty consistently across the board in the various studies that we've looked at. There are some additional issues, though, that need to be resolved. One is the limited generalizability that we were talking about. So if this trial is repeated or in subsequent trials, we would need to repeat them in different geographic populations, especially here in the United States. And in those trials, we have to make sure that there are more women and non-white patients that are enrolled so that they're more reflective of the patients that we take care of in our everyday practice. And then an additional issue is the issue of anticoagulation. So that's something that we did not address during this talk because we feel like that was a little bit outside the scope of this, and also because there's not really enough data for that. For patients who have coronary artery disease, but also have an indication to be on anticoagulation, such as someone who has atrial fibrillation, what should we be doing with those patients? Oftentimes they'll be on, for example, clopidogrel and apixaban for a year after PCI. And then after that, we might switch the clopidogrel to aspirin. And the question is, should we be doing that? Does that make sense to do? We don't really know, at least from the search that we've done, that there's any significant data that tells us what to do in that respect. And then finally, what's the role of precision medicine in all of this? Can we develop more specific risk calculators that help us individualize the decision based on someone's individual thrombotic or bleeding risk as to whether to put them on aspirin or clopidogrel or ticagrelor? And then how can we utilize new artificial intelligence methods, which I know we've been talking a lot about lately, to see who would stand the most to gain from being on a P2Y12 inhibitor as opposed to aspirin? And then finally, how should we be utilizing platelet assays to determine whether someone might be resistant to an antiplatelet agent? So with that, we're going to leave you with the final thought, which is the question, should there be a guideline endorsement for the use of P2Y12 inhibitor monotherapy when you are far enough out from PCI, or for someone that has medically treated stable coronary artery disease? Or should we even be transitioning patients who are on aspirin to something like clopidogrel for secondary prevention? I think after our discussion, we had, okay, well, this is the responses. And so after our discussion, we had differing opinions about what we should do, but we are looking forward to hearing your thoughts as well. Did you want to show this? Okay. So I guess in the poll, it looks like there was a split of opinion. So in the initial question, which was about a patient who has stable medically treated coronary artery disease, the question was what to do with the antiplatelets. The patient was on dual antiplatelet therapy at the time, even though their PCI, I think, was many years ago. So 35% of people said to continue dual antiplatelet therapy due to the higher risk of recurrent cardiovascular events. 22% said to discontinue clopidogrel and continue aspirin alone, and then 39% said to discontinue aspirin and use clopidogrel instead, or use just clopidogrel. So there was a difference of opinion, but wanted to open it up to the floor so that we could see what others have to say.
Can you talk to us about any effect in your reading, those of you that found any effect modifiers, so to speak, around the choice of aspirin? Thinking about the literature. Substantial concern about the use of aspirin. The reduce the benefit of racemation. Does that come through any of these?
Yeah. Yeah, that's a very interesting point. I don't think that they discuss it in any of, at least any of the trials and meta-analyses that I discussed. I don't know if you saw anything, Sean.
It's true. These work on very different pathways, you know. So even when we think about, like, you know, the early trials of aspirin, they didn't have much, you know, ACE inhibitors or beta blockers that were measured on it. So could there be a compounding effect of aspirin with any, you know, some change, you know, effect having both of them on versus. I hope that the studies show that.
So if you go back to next, yeah, here.
Here?
So if the effect of aspirin and Plavix are the effects are on antithrombotic effects on platelets, why the two curves separate after 6 months to a year?
You're talking about in the bottom left figure?
All of them, no, all three.
Yeah,
The half-life of platelets live for 7-8 days, no? And
Yeah.
you're seeing an effect long after that, a difference long after that.
Yeah, I'm not really sure, to be honest. I don't think that at least from what I saw in the discussions for each of the trials, I don't think that there were any, they didn't have any suggestions as to why they thought that there was this divergence that seemed to happen a little bit later on. But I don't have like a specific, mechanism or idea as to why that would happen after 6 months.
Unless it's an off-target effect of clopidogrel, that really you're affecting vascular biology rather than platelet function somehow. No, that would be, maybe there is another explanation. I would love to hear other people's thoughts, but this doesn't match an effect on thrombosis, on platelet aggregation.
It could be something in this very specific population, because in the aspirin group, we saw that effect, at least from, you know, a lot of trials, was very early on in that first, year. So there's definitely discrepancy in the timing of benefit. Although those studies didn't go out as necessarily five years, but some of them did go out before.
We have one question from the chat. Dr. Sumit Shah said, Sean, Andy, fantastic job with a very complex topic. What factors would go into a risk score, and how would we then move that into clinical practice?
That's a good question. I think, I think the kinds of factors that would have to be included are if there are anything that we know that would cause a patient, for example, to be more prothrombotic. So if the patient has had recurrent ischemic events, I think that needs to be included in a risk score. If a patient has had recurrent bleeding events, that also would need to be somehow included. So I think those are the easiest examples I can think of, because they're sort of finite events that have occurred to the patients. So I think those would be the most helpful kinds of things, but there may be other factors that, are considered to be more prothrombotic in the same way that when we calculate ASCVD risk, for example, there are factors that influence that risk a lot. And then there's risk enhancing factors, which we consider, but aren't necessarily as impactful as the others.
Yeah, I agree. I think bleeding risk is definitely, that geography as well. I think that, there's clearly like a geographic difference in terms of where it came from. And I think that should definitely be there. But, I think the biggest signal we're seeing is the bleeding risk as well. So, perhaps we could go up to the guy on a lot, especially for high risk. That much downside, unless there's compelling data, like a 10-year analysis that shows that maybe that separation of signal for that slowed down.
Good job, guys. So I know none of these studies address this, and it's a slightly off topic, but since I've talked to both of you about this in clinic over time, I wondered if you could comment on where our threshold for defining something as secondary prevention is these days. Again, I know that's not what you talked about, and that wasn't in the trials, but we have so much vascular imaging now in patients and all the CAC scores that we're dealing with, and some which are pretty advanced, even in people who haven't had a clinical event. So maybe just speculate a little bit. Put you on the
Do you
spot.
want to go first or do you want me to go?
I forget who coined the term, but I think they call it like coronary disease 1.5. I think that with all of the new imaging, we can definitely detect coronary disease that, maybe hasn't, resulted in complete ischemia yet. But I think that if a patient has coronary disease on imaging, then they should be treated as secondary prevention. And, I think that if you look at all the earlier, for post exam, that's definitely post PCI fine. But for the earlier benefit where they're looking at the benefit of aspirin, I mean, that was kind of like a mix of kind of primary, secondary, because they didn't really have, not everyone was getting stented. And those patients were still we knew they had coronary disease. They weren't getting stented. It's basically medical management, and aspirin was still benefiting them. So I think that, those patients, are a little bit further out from 1.5, but are still pretty close. And, I think those patients should still be considered as being secondary prevention. So I think unless they had a very high risk of bleeding, I think that I would be willing to chat with them and say, I think that you should be treated with.
I would say a majority of those patients ended up getting CAS or some kind of imaging because they had symptoms that were, let's hopefully say, consistent with ischemic events. Now, we have patients coming from the Princeton Longevity Center saying, I'm great and I ride my bike 25 miles a day, but I have this coronary artery calcium score and it's not considered low. And so I think we're in a little bit of a quagmire in that regard. But
yeah, I think there are also differing conclusions that have been drawn in different studies that looked at aspirin for based on coronary calcium alone, for example. I think there was one that I saw that was in circulation that said, I forget what the exact cutoff they used was, but they said that for people with a coronary calcium score higher than that number, they would benefit from being on aspirin. But then I saw a kind of similar study also in a high profile journal that said that was not true. So I feel like there's not really congruency between the different studies that I've seen published. And I guess my personal kind of bias is that I question, for patients that get a coronary CTA and have like a 25% lesion, I personally question what the utility or how much they're really benefiting from being on something like aspirin. So I generally, I guess I personally would not put them on aspirin for that. And I would only do statin therapy, but that's just sort of based on my interpretation of the data.
I think classically clinical events would define.
Sorry, I have a comment to make here. Can you hear me?
Yeah, go ahead, Arya.
So actually, I have been looking to this data, and most of the benefit is not because of chronic coronary artery disease, but rather post-MI. I mean, most of the patients who benefit from it have had some sort of MI, not just coronary artery disease, regardless of the degree of the disease. Can you talk into that? I mean, that's from what I have reviewed so far. Is that different what you have reviewed?
I think in some of the trials, patients had previously had an MI, but that wasn't, that wasn't the only criteria for enrollment. For example, host exam, it was patients who were post PCI, so they didn't necessarily have.
No, PCI, I understand. No, I'm not talking about PCI. Somebody has a stable chronic coronary artery disease. The studies haven't clearly shown they benefit from that secondary prevention you're talking about, unless they had some event or they had intervention. I understand this.
I mean, I definitely agree. I mean, the data, like going back to these meta-analyses. Yeah, so I mean, looking at the various RCTs that are included in these meta-analyses, yeah, the majority of them are not medically treated patients. And those that are medically treated stem mostly from like the ASCET, CADET, and the CAPRI trial. And those, they've had MIs, but the ones before that, I think, and the aspirin trials from the Antithrombotic Coalition, many of them, you could say maybe you are not necessarily fully having an event. I think that the definition of myocardial infarction probably back then was maybe a little bit different than it is today. So maybe those patients are more medically treated. And those patients are maybe not fully had a full like event that would be consistent with today's like requiring a PCI.
Okay.
So but again, that data, like, for those earlier trials is not that strong. So I agree. I also have pause. When people start changing their, like, let's say you have a patient of Dr. Glenn Henry come in that you've now inherited, and he's 70 years old. He's been on aspirin monotherapy for secondary prevention. Would you change him to a, Plavix or Ticagrelor, or would you just let him be? He has, GERD, prior history of minor GI bleed. Would you go ahead and just say, hey, let's just change him over? And then he comes back, a month later saying, hey, doc, you changed my med, and then I had a heart attack. I feel like, I think, and he happens to be like, Pakistani or Bangladeshi, and, turns out he has, a SIP.
Are you telling a real story?
No, I'm not. I'm just saying, like, that's something I think about. Like, should we start, like, I think I would have a lot of pause about changing people over like that. I think if I had a new patient come in post PCI, that, I'd say, okay, yeah, sure. Like, it makes sense. I could start adopting that. But, I think I'd really think about the geography before, giving somebody that lifelong. And I think nowadays, like, looking on GoodRx, $5 for 90-day supply of Plavix and $5 for a good, 90-day supply of aspirin. It's about the same. So I don't think cost is really a limiting factor. And there's not really another clear side effect.
I think age is a modifier here. As you get older and older, the risk of bleeding increases with age. I think those are considerations, but I don't know if I would, your example, just to be upfront, I'm not sure I would change that individual. But I would strongly consider this data initiating.
Yeah.
I mean, if I can make a comment also, that, as you know, is CYP2 C19 that you look at, and you talked about it in East Asians. There are all the variants actually that also involve in metabolism, the CYP2 B6 and A2. So it would be actually interesting for any of you interested to look at the UK Biobank database, and they have events, and see, if in the East Asian population, is there any other factor that involved in that, despite the fact that actually they have more kind of null allele in CYP2 C19, whether there are other alleles that actually can change this and be protective.
All right, thank you.
very difficult.
That was tough.
The less you know, the better you feel. Always.
Awesome job.
Yeah, thanks for coming out.